Welcome to the deep dive. Today we're tackling a really interesting area, minimally invasive surgery for chronic pain management.
That's right. And our main source here is minimally invasive surgery for chronic pain management, an evidence-based approach. It's edited by Giorgio Pietramaggiore and Sadia Sher.
A practical guide, really.
Exactly. It's aimed at surgeons, giving them the latest on these less invasive techniques for peripheral nerve issues that cause chronic pain, nerves outside the brain and spinal cord.
Right. And for you listening, we're going to pull out the key insights, give you a clear understanding of what's happening in this field. It's moving pretty fast.
It really is.
So let's start with the forewords. Pretty strong endorsements in there.
Yeah, from leaders in plastic and reconstructive surgery and also Harvard Medical School. They both really stress how important peripheral nerve surgery is becoming.
And they point to a need for innovation, right? Especially minimally invasive stuff.
Absolutely. They highlight that need. And interestingly, they mention literature reporting over 70% pain improvement with these surgeries.
70%. Wow. That's significant.
It really suggests a lot of potential benefit for people struggling with this kind of pain.
Okay, so turning to the preface, the editors themselves, Pietramaggiore and Scherer, they talk about why they put this guide together.
Yeah, they mention the frustration, both for patients and doctors, when chronic pain just lingers and doesn't get better.
I can imagine.
And they really emphasize how critical precise diagnosis is. Finding the exact cause, especially if it's nerve compression or nerve injury.
Which leads into their 3 golden rules for considering this type of surgery for neurogenic pain, nerve-related pain.
Right. These are sort of fundamental guidelines. First rule.
Wait, how long?
At least 6 to 12 months from when the symptoms first started.
Okay. Why the wait?
Well, it acknowledges that some conditions might just get better on their own. You don't want to rush into surgery unnecessarily.
Makes sense. Patients first. What's rule number 2?
Rule 2 is about diagnosis confirmation, using selective nerve blocks.
Ah, the blocks. We'll talk more about those.
Yeah. The key here is aiming for what they call a significant wow effect.
A wow effect.
Meaning, if numbing a specific nerve gives you, the patient, really dramatic pain relief, even temporarily, it's a very strong sign that that nerve is the problem. And that surgery focused on it is likely to work.
Got it. Like a test run for the surgery's potential. And the 3rd golden rule?
Preserve the nerve whenever possible. That's the core idea.
So don't just cut it out.
Exactly. Unless it's, terminally damaged beyond repair, the focus should be on decompression, taking pressure off it.
Okay.
And neurolysis, freeing it from any scar tissue that might be trapping it. Basically, giving the nerve the best environment to heal and function.
Decompression, neurolysis, liberation. Got it. So preserving the nerve. Now, this book covers quite a range of conditions.
Oh, definitely. It dives into the surgical anatomy, the diagnosis part first, then specific things like painful neuromas, those tangled nerve endings.
Right.
Neurovascular, temporal headaches, temple pain involving nerves and blood vessels, occipital neuralgia, back of the head pain, pectoralis minor syndrome, that's a shoulder nerve compression issue.
Okay.
Groin and genital pain, central wrist pain, and even, interestingly, nutritional advice, like ketogenic diets.
Quite the scope. Let's start where they start. Chapter 1, Surgical Anatomy and Diagnosis. It lays the groundwork by describing the symptoms of neuropathy.
Yes, and these symptoms can be really debilitating. Things like dysesthesia.
Which is like an abnormal sensation, burning, tingling.
Exactly, unpleasant. Then hyperesthesia, extreme sensitivity to touch. Cold intolerance is common too. And allodynia.
Allodynia. That's when even light touch causes pain, right?
Precisely. Things that shouldn't hurt do. And all this, understandably, often leads to sleep problems, anxiety, depression. It affects the whole person.
A real cascade effect. So the chapter explains that doctors suspect neuropathic pain when these symptoms occur in areas where nerves are known compression points, or maybe where there's scar tissue from a previous injury or surgery.
Right. And they mention a key physical exam finding, the Tinel sign.
Ah, tinels, like hitting your funny bone?
Sort of, yeah. It's when gently tapping over the suspected nerve pathway triggers that tingling pins and needles feeling down the nerve's distribution. A positive Tinel sign is a good clue.
A simple tap tells the story. But to really zero in, they detail the diagnostic nerve block. How does that work exactly?
It involves injecting a very small amount, usually just 1 to 5 cc, like a teaspoon of local anesthetic, often lidocaine, maybe with epinephrine.
And they use ultrasound?
Yes, crucially, under ultrasound guidance. This lets them see the needle and the nerve. The injection goes just proximal to the suspected compression or injury site, meaning closer to the body's core.
And the goal is immediate pain relief.
Exactly. A block is considered positive if the patient reports at least a 50% reduction in their pain, pretty much right away, both when resting and when moving.
50% or more.
Yeah, sometimes it's almost complete relief, that wow effect again.
And it's not just about the pain score, is it?
They also ask important follow-up questions right after the block. Can you now touch areas that were too sensitive before? Can you move in ways that were previously painful?
Trying to gauge functional improvement.
Right. And critically, they ask about potential satisfaction with surgery. Questions like, if surgery gave you this much relief, would you be happy? Would it help you get back to work or daily life? And importantly, would you risk the pain possibly getting worse to achieve this level of improvement?
Those are tough but necessary questions. Helps set expectations, and they recommend doing the blocks more than once.
Yes, at least twice.
Yeah.
Before considering surgery. It's about confirming the diagnosis, making sure that nerve is consistently the culprit.
Doubling down on certainty. The chapter also strongly pushes for using high-frequency ultrasound probes for these blocks. Why the emphasis?
Because it allows for real-time visualization. You see the nerve, you see the needle, it makes the diagnosis faster, more reliable, and importantly, safer.
Better tech, better results.
And they point out that it's becoming more accessible. Smaller, more affordable probes. Some even hook up to tablets or phones. Plus, using special blunt-tipped needles that show up well on ultrasound adds another layer of safety.
So visualization is key. Okay, moving to the actual surgical approaches. It depends on the nerve's condition, right?
Absolutely. If the nerve is just compressed, but not fundamentally injured, the standard is nerve decompression.
Just freeing it up.
Exactly, like unkinking a hose.
Yeah.
But if the nerve is injured from trauma, maybe previous surgery, then nerve reconstruction is often the way to go. This might involve using nerve grafts.
Grafts, like borrowing nerve tissue.
Yes, either from elsewhere in the patient's body, an autograft, or from a donor source, an allograft.
And what if reconstruction isn't possible? Like the nerve is too damaged or you can't find the ends?
That's trickier. In some cases, selective directomy might be an option. That means removing the damaged nerve segment.
But you mentioned neuromas earlier. Isn't there a risk?
Yes, that's the main drawback. Removing the damaged part can sometimes lead to a new neuroma forming on the remaining healthy nerve end further up. So neurectomy is usually reserved for situations where a neuroma has already formed and reconstruction just isn't feasible.
A decision with trade-offs. And they stress clear patient communication.
Hugely important. Patients need to understand all the possibilities, including what the surgeon might find during the operation. And crucially, they need to know that surgery isn't a guarantee. Pain might not improve, or rarely it could worsen. Managing those expectations is vital.
Definitely. Okay, so the book then applies these diagnostic block techniques to specific conditions. Let's start with neurogenic temporal headaches in the temple area.
Right. These can involve the auriculotemporal nerve, the ATN, or the superficial temporal artery, the STA. The key diagnostic test is blocking that ATN, ideally during a headache.
But that sounds hard to coordinate.
It often is, practically speaking. Getting someone into the clinic mid-headache isn't easy. But if a block provides significant sudden relief during an episode, it's a very strong sign that surgically decompressing the ATN could work.
And the artery, the STA.
They can check blood flow in the STA with Doppler ultrasound and inject anesthetic around it too, as part of figuring things out.
Okay. How about occipital headaches? Back of the head pain, that seems common.
Very common. Mainly caused by compression of the greater occipital nerve, GON, and the lesser occipital nerve, LON. Patients often have this sort of background ache with sharper flare-ups. These nerves come from the upper neck, C2 and C3.
And there's a typical spot where they get squeezed.
Yes. A common compression point is the nuchal line, that ridge at the base of your skull. They often cross the occipital artery there, and while the nerves themselves can be hard to see with ultrasound right there.
Let me guess, the artery is easier.
Exactly. The occipital artery is a reliable landmark, so they use Doppler to find the artery at the nuchal line and then inject the anesthetic, maybe with some cortisone, right around it.
And that should relieve the pain.
Should provide immediate relief on that side of the back of the head. Sometimes it even helps pain radiating towards the eye or temple.
Interesting how it radiates. Now, pectoralis minor syndrome, neurogenic thoracic outlet. The compression is under a chest muscle.
That's right, the pectoralis minor muscle. It compresses the brachial plexus, the nerve bundle going to the arm, and often the artery and vein too.
So how do they diagnose if that specific muscle is the problem?
by injecting local anesthetic directly into the pectoralis minor muscle itself.
Ah, to relax it temporarily.
Precisely.
Hmm.
If relaxing that muscle with a block improves arm movement and reduces pain, it points strongly towards pectoralis minor syndrome. They use ultrasound to guide the needle into the muscle body.
Makes sense. Targeting the muscle. Okay, shifting to groin and genital pain. Which nerves are usually involved?
Typically the ilioinguinal, iliohypogastric, and genitofemoral nerves. Often the issue stems from nerve injury during previous groin surgery, like hernia repair.
And diagnosis here is a bit more difficult.
It can be. Those first two nerves, the ilioinguinal and iliohypogastric, run pretty deep in the abdominal wall, making them hard to visualize clearly with ultrasound.
So how do they block them?
It's more of an anatomical block. Using ultrasound, they guide the injection to the layer between the internal oblique and transverse abdominal muscles, roughly level with the belly button, where the nerves are expected to be.
Kind of a landmark-based approach. What about the genitofemoral nerve?
If blocking the other two doesn't help genital area pain, they might try an ultrasound-guided block targeting the genitofemoral nerve near the external inguinal ring.
Okay, and finally, for diagnosis, central neurogenic wrist pain.
Right, pain in the middle of the wrist, not caused by instability. This can often be addressed by targeting two specific nerves, the posterior interosseous nerve, PIN, and the anterior interosseous nerve, AIN.
They supply the wrist joint itself.
Primarily the joint capsule, yes. The PN handles the back or dorsal side, and the AIN handles the palm or volar side.
And again, diagnostic blocks.
Yes. Ultrasound-guided blocks target the PN and AIN in the distal forearm, just above and below the membrane connecting the two forearm bones. If these blocks significantly reduce central wrist pain, it suggests denervation surgery might help.
That covers the diagnostic phase thoroughly. Let's move to the second chapter, treating painful neuromas, including this technique called targeted muscle reinnervation. First, remind us what a neuroma is.
Basically, it's a disorganized, tangled growth of nerve fibers that forms after a nerve injury. Could be from a cut, blunt trauma, stretching, surgery, amputation.
A painful knot of nerve tissue?
Exactly. It can happen at the end of a cut nerve or even along a nerve that was only partially damaged, a neuroma in continuity. They mention classifications like Sunderland's and McKinnon's, linking neuroma formation particularly to more severe injury types.
And they cause significant problems.
Oh, absolutely. Chronic pain, often that burning dysesthesia or hyperesthesia, paresthesias, cold intolerance, a positive tinel sign right over the neuroma, and loss of function because it just hurts too much to use that area. It can lead to opioid dependence, major quality of life issues.
So diagnosis relies on history and exam.
Mostly, yes. History of injury or surgery in that area, the specific type of pain, finding that tinel sign, maybe sensory changes further down, and crucially, getting temporary relief with a diagnostic block just proximal to the neuroma.
Okay. What are the general principles for surgically treating them?
Careful planning is key. The incision is often made a bit proximal to the neuroma itself. Then, very careful dissection to free the neuroma from scar tissue. You need to expose healthy nerve both above and below the neuroma.
And finding that healthy tissue is critical.
Absolutely vital.
Okay.
The surgeon has to resect the nerve, cut it back, until they see healthy nerve fascicles, often confirmed by seeing tiny points of bleeding within the nerve, bundles what they call endoneural bleeding. That signifies healthy tissue.
Starting fresh, essentially. So what if there is still a target for the nerve further down, like it wasn't an amputation?
Then the goal is nerve reconstruction, restoring continuity. If the gap is small, direct repair, stitching the healthy ends together without tension, is ideal.
And if there's a gap?
For small gaps, maybe connector-assisted repair using tiny tubes or nerve wraps. For larger gaps, say between 1 and 7 centimeters, nerve grafts are often needed using autograft or allograft tissue.
Okay, but what about the situation where the original target is gone, after an amputation, for instance?
Right, that's where you need to create a new destination for the regenerating nerve fibers to prevent them from forming another painful neuroma. There are several strategies.
Such as?
Nerve implantation, burying the nerve end in muscle or sometimes bone. Central neurography, connecting it to another nearby sensory nerve. Nerve destination relocation, using a graft to redirect it somewhere less problematic, a graft to nowhere, sometimes called. Regenerative peripheral nerve interfaces, or RPNIs.
RPNIs?
Where you wrap the nerve ending in a small piece of muscle, giving the axon somewhere to grow into.
And then there's targeted muscle reinnervation, TMR. That sounds specific.
It is. TMR involves surgically connecting the cut sensory or mixed nerve ends to the motor nerves of nearby, otherwise denervated muscles.
What's the goal there?
Twofold, really. It provides a functional target for the regenerating axons, reducing neuroma pain. And especially in amputees, it can allow for more intuitive control of advanced prosthetic limbs because activating those reinnervated muscles can be picked up by sensors.
Fascinating. Any other techniques mentioned?
Briefly, yes. Targeted nerve implantation, TNI, is similar, focused on pain control. Sometimes they combine techniques like TMR with a vascularized RPNI, where the muscle graft has its own blood supply. They also mention nerve caps and nerve ablation chemical or radiofrequency. But note, these might be less reliably effective.
A lot of options. What's recovery like after neuroma surgery?
Pain is managed post-op. Pre-existing pain meds are tapered down. Showering is usually okay after a few days, but movement around the repair site needs to be protected for several weeks. Strenuous activity is usually off limits for about 3 months.
And the pain relief, is it immediate?
Sometimes, but often it's gradual improvement over 2 to 6 months. The overall success rate is reported around 70%. But patients need to know neuromas can sometimes recur.
Okay, good overview. Let's circle back to those neurovascular temporal headaches. We talked diagnosis, now treatment. What's the surgical fix?
When conservative treatments fail for that pulsating temple pain along the ATN and STA, especially if pressure or cold helps, then surgical decompression can be effective.
Decompression, taking the pressure off again.
Exactly. It's a nerve-preserving technique. Small incision in front of the ear. They find and free up the superficial temporal veins. Then carefully release the ATN from any tight ligaments. And the STA is also decompressed arteriolysis, separating it from tight tissue and any tiny nerve branches wrapped around it.
Sounds
It is. And they might biopsy the artery if arteritis is suspected.
What's the recovery from that one?
Usually pretty fast. Tape off in a few days, return to normal activity, often same or next day, maybe strenuous activity held for a week. The aim is permanent relief, which they report in about 80% of patients, often kicking in within days to 3 months.
80%, that's encouraging. Next, occipital neuralgia treatment. Back of the head pain, GON and LON nerves. Surgical approach.
Again, the preference is minimally invasive and nerve-preserving. Small, angled incision in that occipital triangle area at the base of the skull.
Wow, there.
Gives good access to decompress the GON and LON neurovascular bundle right at the neutral line, a key compression site. Can also address GON compression points higher up through the same incision.
And what do they actually do in the surgery?
They release the tight fibrous attachments of the trapezius and sternocleidomastoid muscles from the neutral line. That takes pressure off the nerves. Any enlarged lymph nodes pressing on nerves might be removed. They also carefully check the occipital artery's path and free up any nerve contact points, sometimes ligating small arterial branches if needed.
And recovery.
Often fairly early pain relief, continuing to improve over 1 to 3 months. Some temporary scalp sensitivity is common, usually resolves. Major complications are rare.
Good. Okay, pectoralis minor syndrome treatment. Releasing that muscle.
Right. The surgery involves releasing the pectoralis minor tendon from where it attaches to the coracoid process on the shoulder blade.
How to do that?
Small incision at the front of the shoulder. Careful dissection to protect nerves and veins. Retract muscles to expose the pec minor tendon, then release it, usually using bipolar coagulation to control bleeding.
And post-op.
Early mobilization is encouraged. Gradual return to activity. Strenuous stuff like throwing or heavy lifting, usually okay around 3 months post-op, building up slowly.
Got it. Now, groin and genital pain treatment. Ilioinguinal, iliohypogastric, genitofemoral nerves. What's the surgical plan here?
It's often either neurolysis freeing the nerve from scar tissue or neurectomy removing a section. Because nerve injury is common here, especially post-surgery, neurectomy of the damaged segment, going back to healthy nerve tissue proximally, is often preferred.
And the procedure itself?
Incision parallel to the inguinal ligament. Identify the nerves, often on or in the internal oblique muscle. Dissect back from the scar tissue to find healthy nerve. Cauterize and remove the damaged part until they see that healthy intravesicular bleeding. Then implant the proximal nerve end into muscle to discourage neuroma formation.
Similar for the genitofemoral nerve.
Yes, similar process, just being extra careful around the spermatic cord structures in males.
Recovery and outcomes for groin nerve surgery.
Expect some post-op pain, managed with meds. Avoid heavy lifting for a few weeks, but normal daily activities resumed fairly quickly. Strenuous activity held for about 3 months. Most patients get good relief within 3 months. Some take up to 6. Success rates are around 80%. If pain persists, a different approach, retroperitoneal, might be needed.
Okay, last surgical condition. Central neurogenic wrist pain treatment. targeting the pin and AIN.
Right, partial wrist denervation. The idea is to selectively cut the sensory nerves supplying the central part of the wrist joint capsule.
How's it done?
Usually a single incision on the back of the wrist. Expose the extensor retinaculum, make specific cut in it, move tendons aside, find the pin above the interosseous membrane, resect a segment, bury the end in muscle. Then make a window in the membrane, find sensory branches of the AIM below it, resect a segment, bury that end too. Close the retinaculum and skin.
And a recovery for this one.
Typically minimal pain. No immobilization usually needed. Early wrist movement is encouraged. Relief is often immediate and lasting for that central wrist pain.
That covers a really wide spectrum of surgical interventions. And interesting that the book wraps up with a chapter on nutrition, specifically keto diets.
Yeah, a brief look at ketogenic or low-carb diets. Very low-carb, high healthy fat, moderate protein. Shifts metabolism to using ketone bodies for fuel.
Which is used for epilepsy.
Exactly. Established for refractory epilepsy and also weight loss. This chapter explores its potential role in pain management, possibly through effects on inflammation or nerve function. They point listeners to the Epilepsy Foundation website for basic food guidance.
A holistic touch at the end. So pulling this all together, it's clear there's a whole toolkit of minimally invasive surgical techniques for these chronic peripheral nerve pain issues.
Absolutely. The theme is addressing the root cause compression or injury, but with less disruption than older, more open surgeries.
And that precise diagnosis, using the blocks, using the ultrasound, is just paramount.
Crucial for selecting the right patients and targeting the right nerve. It's not for everyone, but for the right person. It can make a huge difference.
And managing expectations is key throughout. Patients need the full picture, potential benefits, risks, recovery timelines.
Definitely. So for you listening, if you're dealing with persistent chronic pain that might fit these descriptions, it could be worth discussing these less invasive options with your doctor. They might open up new avenues.
Absolutely. And a final thought to leave you with. We've talked about nerves getting compressed or injured in all these different spots. Considering how complex our nerve network is, how might future advances in imaging, maybe even higher resolution ultrasound or specialized MRI, further refine how we diagnose these problems? Could we one day pinpoint these issues even more accurately, leading to even more tailored and effective treatments? Something to think about. Thanks for taking this deep dive with us.